The Gerontological Society of America, Meaningful Lives as We Age.
Welcome to this GSA Momentum Discussions podcast episode titled The 5-Cog Paradigm, an innovation to improve detection and management of impaired cognition in primary care. Momentum discussions highlight topics experiencing great momentum in the field of gerontology. We're grateful to Genentech, Lilly, Eisai, and Otsuka for their support of the GSA Care Toolkit for primary care teams and today's podcast episode. My name is Jen Pettis, and I'm the Director of Strategic Alliances at the Gerontological Society of America, or GSA, and I'm pleased to serve as a host for today's Momentum discussion. I'm delighted to be joined by Dr. Joe Verghese, a professor in the Saul R. Korey Department of Neurology, the Murray D. Gross Memorial Faculty Scholar in Gerontology, and the Chief of the Divisions of Cognitive and Motor Aging at Albert Einstein College of Medicine. He's also an attending physician in the Department of Neurology and the Chief of the Division of Geriatrics for the Montefiore Health System. Earlier this year, Dr. Verghese and his colleagues reported the results of the 5-COG study in Nature Medicine. This study was funded by the National Institutes of Health, or NIH's, National Institute of Neurological Disorders and Stroke, in collaboration with the NIH's National Institute on Aging. The 5-COG study is a participant in the Consortium for the Detection of Cognitive Impairment, or DETECT-CID, which is available at detectcid.org. I'm delighted to have this opportunity to chat with Dr. Verghese, who led the 5-COG study. Welcome, Dr. Verghese. I'm so glad you could join me.
Thank you very much, Jen. It's a pleasure to join you today.
So, Dr. Verghese, in the paper recently published in Nature Medicine, you and your colleagues discussed barriers to implementing routine screening and related care processes in primary care. What are some of those barriers?
The rapid aging of populations in U.S. and throughout the world has resulted in a rise in a number of age-related diseases, including dementias like Alzheimer's disease and just in general cognitive impairment among the older population. Most of patients who have cognitive concerns or cognitive impairment are seen by primary care physicians. And that's where most of the dementia action, as you would call it, happens in primary care clinics. It's said that in varying surveys that up to 50 to 80% of cases, though unfortunately, are missed in primary care clinics. And there are many barriers that account for this. So in terms of screening, the barriers can generally be considered at the level of the screening instrument or at the primary care physician level, patient level, or the healthcare system. So the barriers with the screening instruments that we have is many screening instruments are long. They require specialized training, they require specialized personnel, and they require usually clinicians to administer these tests. Many of them are not free either. Another major barrier is that once you've done these screening tests and you get a normal or abnormal results, there's often no guidance as to what the next step you need to do. In fact, the United States Preventive Task Force, in their recommendations from a year or two ago, said that there was no evidence for benefits or harm of doing routine cognitive screening in older patients. A big difference between those recommendations and our study is that we focused on patients with cognitive concerns, a big population, up to 40% in our primary care settings, and a population that wasn't targeted by the USPTF, the United States Preventive Task Force recommendations. The other barriers at the physician level are that primary care physicians are just too busy. They don't have time to do elaborate screening. They often, have to struggle with multiple priorities. It's said that in the US, on the average, a primary care physician gets to spend between 15 to 17 minutes with a patient. And in that time, they have to address up to 6 medical issues. So a patient might have come with a sprained ankle or a cough, and then you're adding on cognitive screening and dealing with that into this really limited time. So that's definitely another barrier. At the system level, our systems don't account for this rising tide of cognitive concerns and impairment among older patients. There is some preliminary attempts in enabling screening in clinic and appropriate reimbursements, but still is not widespread. So we don't have that available in all centers. So these are some of the multiple barriers that face widespread implementation of cognitive screening and associated care actions in the primary care.
And Dr. Verghese, next, can you address the unmet needs around detecting cognitive impairment in Black and Hispanic individuals in particular?
Sure. I mean, that is a serious problem and concern. Most cognitive tests and screening instruments have been developed in Caucasian and white populations, and they are applied to other minorities, including underserved minorities like African American or Hispanic populations, and often not appropriately. In our population, for instance, a widely used cognitive screening test is the Montreal Cognitive Assessment, or the MoCA. And we showed that recommended cut scores that were developed in white populations were inappropriately high in Hispanic and African American populations in our primary care. Another issue is to do with literacy issues in a lot of these communities. And in our population, we have a lot of patients who are high school or less than high school level education. And many tests require you to have a degree of literacy. And by requiring that, they exclude people who have low literacy. Another barrier is just cultural barriers. Items that are developed in one population might have a completely different meaning in another population. For instance, in our primary care clinic, we showed that cognitive concerns that were questions that were developed in white populations, when we looked at the same questions in Hispanic or African American populations, they were more related to depressive symptoms rather than cognition. So there has to be a degree of cultural sensitivity that needs to be applied. So these are some of the issues when you have screening approaches that are also meant to be applied to underserved minorities.
So how does the 5 cognitive detection tool address those unmet needs that you discussed and those issues with the underserved populations?
So the 5-cog, as the name suggests, 5 comes from the fact that it takes only 5 minutes to do. And so it takes less time. It's quick. It's easy to train. We've trained community health workers, social workers, undergraduate students, different groups of people to actually administer the test. And it's been an easy process to train people. The 5-cog is given before the patient sees the primary care physician. And in a clinic setting, that screening can be done by a community health worker or a licensed practice nurse. Or in fact, an office staff, you could train an office staff to give it. And this reduces the burden on the primary care physician. The other important element to realize about the 5-cog is the 5-cog is not just a screening test alone. It's paired with recommendations. So it's the 5-cog paradigm and the approach that we are promoting. So once a patient gets the test done, it generates a series of recommendations that are passed on to the primary care physicians that guides them into the next step. So that's another major barrier that is eliminated. As we discussed earlier, the 5-cog, the individual items are picture-based or questions, and they're designed to be applied to different populations. Now, I've been asked about this before. Is 5-cog only meant to be applied to Hispanic or African American populations? And that was because in our clinical trial, we had over 90% of representation from these communities. But absolutely not. The 5-cog is meant to be applied to all populations and all the races and ethnicities. It is just that, unlike many other cognitive tests, it is also applicable to underserved minorities.
And you mentioned that it was the detection tool itself, the screening part was done before that patient got to the clinician, to the provider. So tell us about the elements of the 5-cog, but then also who was conducting that and kind of how was that done when that assessment was used during this study?
Sure. The 5-cog consists of 3 tests. The first test is a test called the Picture-Based Memory Impairment Screen. And this is a visual memory test. It consists of 4 pictures that are presented to the patient. The patient identifies them, and these pictures are usually in different categories. Say, for instance, we might have a hand or a grape or a bicycle. And then the patient is asked to identify the pictures, and then we give them the categories to cue them. So, for instance, after they've identified all the pictures, we would ask them which is the body part, and they're supposed to say hand, or which was a fruit, and they're supposed to say grape. So once they've learned that, then we put aside the pictures, and then we move on to the other 2 parts of the 5-cog. So the second part of the 5-cog is another picture-based test where you are matching abstract symbols to numbers. So they're given a series of symbols, and then they have to write the appropriate numbers underneath them, and we see how many they can do in 90 seconds. So this is called a symbol match test. And this tests non-memory domains because the picture-based memory impairment screen is a memory test, and people might have other non-memory impairments early in the course of cognitive decline. The final test is based on the concept that over the last 2 decades, we realized there are non-cognitive manifestations of cognitive decline. So traditionally, when we think of dementia, we think of it as a cognitive issue with memory problems or executive function problems. But other non-cognitive manifestations have been described like poor sense of smell or hearing, but an important marker is walking slow. So we've shown that people who walk slow are at increased risk of dementia. And we proposed a pre-dementia syndrome. It's a syndrome that identifies people at high risk of converting to dementia called the motoric cognitive risk syndrome. The motoric cognitive risk syndrome is a combination of cognitive complaints plus slow gait. So we capitalized on this finding to include slow gait as a screening test because we were identifying people with cognitive concerns. So if we identified that they also had slow gait, they more or less met criteria for motoric cognitive risk syndrome. So those are the 3 tests. And once we've, for the motoric cognitive risk syndrome, then all we do is we take the patient onto the hallway, ask them to walk a fixed distance in different settings. It could be either 8 feet or 10 feet. We mark it on the floor and they just timed walking this. And then we have cut scores that determine whether patient walks slow or not. And similarly, we have cut scores on the picture-based memory impairment screen as well as the simple match. And after the patient finishes the walking, we bring out those pictures we showed before, and then we get the patient to recall them. If they can't recall the pictures freely, then we give them the category cues, and there's a scoring that's developed to account for how do they get these, how many items did they get and how many items did they need cueing on. So that is the 5-cog in a sense. It's the 3 tests. And abnormalities on any one test is enough to trigger recommendations because we believe that, while being abnormal on all 3 tests might suggest a high degree of impairment, we think it's important that even if you have abnormalities on any one test, that's good enough. Before we implemented these tests in the primary care clinic, we had lots of consultations with primary care clinicians. And the feedback that they got from us was that they really wanted to make sure that they did not miss a true case of cognitive impairment. In other words, they wanted the sensitivity of the test to be very high. If they missed the case, our recommendations in Screen Negative is that they'd retest a year later. So it's not that when you're having patients with regular follow-up that you'll completely miss a patient. The detection might be delayed for a year, but still, I would say very early in the course of cognitive decline.
And you mentioned the 5-cog paradigm, that you have combined this screening with electronic medical record or EMR embedded clinical decision tree. Can you tell our listeners about the paradigm and then the outcomes of implementing that?
The 5-cog paradigm is the combination of the 5-cog screening test, which are those 3 tests that I described, plus a set of electronic recommendations. So broadly, there are 2 sets of recommendations. There's either a screen positive, which means that you had an abnormal performance on one of those 3 tests, or a screen negative, in which case you cleared all 3 tests. When the test is administered in our setting by a community health worker, and once the community health worker gave the 3 tests and compiled the results, they enter the results into our electronic medical record system. And we've worked with the electronic medical record system programmers to create an alert. So then an electronic alert pops up on the primary care provider's screen when they see the patient to say that this patient went through the 5-cog screening test, and here's the result. It's either positive or negative. If the tests were negative, by which we mean that the patient had no issues on all 3 tests, then the recommendation was just that they had cognitive concerns because that's the way they entered into the test, but the tests were negative. We would recommend that you repeat screening in a year's time. If the test was positive, then there was a different set of recommendations. We would say that this patient was at high risk for having either mild cognitive impairment or dementia. It's important to know that tests like 5-cog are not diagnostic tests. These are screening tests, so they don't make the diagnosis. They just indicate somebody's at risk. So we were very careful in not saying that this actually can be used just for diagnosis. And that's the same with any other screening test, like the mini mental state exam, the MOCA, the mini-cog, or the many other tests that have been developed. These are all screening tests. And some of the recommendations we make is, consider assigning a diagnosis of either mild cognitive impairment or dementia after you do further testing, or send the patient for further evaluation, or consider doing laboratory investigations to rule out causes of cognitive impairment, because dementia is not the only cause for cognitive impairment. Cognitive impairment concerns could arise because patients are depressed, or they have sleeping issues, or they have anxiety. So the primary care physician needs to consider these other steps. And finally, these recommendations were not prescriptions to the primary care physicians in that they had to follow them. These were just recommendations. So they could choose to follow them or not, because after all, we were doing a 5-minute test. And for most primary care physicians, they're seeing a patient whom they might have been seeing for years. So obviously, they know much more about the patient than a 5-minute test. They might not have had time to address some of these issues, or the patient might not have expressed cognitive concerns to them. And this is a way of alerting the primary care physician and then guiding them if they need help into the next step. In our study, it was interesting. We had a positivity rate of about 40% on the 5-cog. So of all the patients that we gave the 5-cog, about 40% had an abnormal result on any one of those 3 tests. And in those patients, again, roughly, the primary care physicians chose to act in about 40%. So in the majority of the patients that had a positive result, they decided not to act. And the reasons might be, again, like I mentioned, because they know the patient much better than we do. They took an action, they noted the abnormality, but then decided that they knew what the reason for that was, and it was probably already being addressed, or they had a plan to address it. So it's important to note that, primary care physicians use their own judgment in making patient decisions, and this is just a way of assisting them in making these decisions.
How was the patient acceptance and the clinician feedback about the 5-cog paradigm? I'm interested to hear what they had to say.
Yeah, it's interesting. There was a sort of a different perspective. Yeah, for the patient, we went back and asked patients about their experience, because while the actual clinical trial was going on, we did get informed consent from the patients, and then they went on to have the test. But then we didn't want to disrupt the clinic flow. So as soon as the 5-cog was done, they just went on to see their primary care physician. A few months later, when we asked most of the patients, they didn't even recall having the 5-cog done. So in that way, I think it's a good thing, because it wasn't an obstruction or a barrier. It's something that was done that they felt as part of the routine clinical procedures. Some of the patients who had the positive results did recall having the test done, and that they discussed this with their doctor, or the doctor discussed it with them. We didn't do a deep analysis of harms that the 5-cog could cause, but from our experience administering that, nobody had a harmful effect. Nobody developed severe anxiety or had blood pressure problems. And those were the same when we examined the primary care physician's notes. There was no mention of that. But it's important to note that, we did the test and we said we were passing the results on to the primary care physician. So the actual diagnosis was either mild cognitive impairment or dementia was done by the primary care physician, taking into account maybe the 5-cog and other investigations that they did. And we didn't track the effect of actually telling the diagnosis, but other studies have shown that, in some patients, if it's not properly done, that can cause harm. Now, from the primary care physician's point of view, I think we got much more feedback, because we really involved them before starting the clinical trial in designing the 5-cog paradigm. We also had primary care physicians on our team, which was a great help. I'm a neurologist, and I've done dementia care for over 20 years, but my care is done in a specialty clinic, which is a completely different world from a primary care. So having primary care clinicians and primary care staff partners, I think, was very important to the success of our study. And they helped design the five-cog paradigm the way it was actually administered. And most of them had very positive views and opinions about the five-cog and felt it really helped their flow.
Well, finally, Dr. Verghese, what's next for the 5-cog? How can others use it in their research and practice, and what's next for the study team?
Sure. I should mention that the five-cog clinical trial that we completed actually ended up with really impressive results, even if I may say so. The five-cog paradigm improved dementia care by threefold. And dementia care, the way we defined in the study, were new diagnoses, investigations done appropriately for cognitive impairment, referring patients to specialists, and ordering prescriptions. The diagnosis rate went up about 5 or 6-fold in the five-cog arm of MCI and dementia. Physicians also made other diagnoses like cognitive loss. The only outcome, actually, interestingly, that wasn't different between the five-cog arm and the control arm was prescription rates. So even though the prescription rates were higher in the five-cog arm, only about 1% or so of patients in the five-cog arm actually got prescriptions done by the primary care physicians. I think there are quite a few reasons. That it could be just that the primary care physicians needed more time to evaluate the results and complete the series of investigations. They did refer a small proportion of patients to specialists, so they might be waiting for the specialists to finish the evaluation or start treatment. And clearly, there might be some physicians who do not believe that the current available medications really work. So there might be many reasons. In our current trial, we're trying to do a deeper dive into some of those reasons. Because as new diagnostic tests become available and new therapeutic options for Alzheimer's and other dementias become available, this is going to be an issue because in specialty clinics, we will only be able to deal with the tip of iceberg of a growing dementia problem in this country. So we need to empower primary care clinicians and clinics to deal with dementia, and that includes ordering right tests as well as starting treatments. So I think that's an issue that needs to be looked at into great detail. In order to address some of these issues, we were funded by the National Institutes of Health to do a pragmatic clinical trial, which we are doing in partnership with Indiana University. My co-PI is Dr. Malas Bustani, who is a geriatrician and has a really accomplished team of investigators. We are going to involve 6 primary care clinics in the Bronx and 16 primary care clinics in Indiana. So we'll have a mix of clinics in urban, suburban, and rural areas. We'll have different populations. We'll have African American and Hispanic populations in both sides, probably more in the Bronx. We'll have rural populations in Indiana. So we are really going to test out the five-cog paradigm in a more real-world setting, which will apply to many parts of the US and hopefully worldwide. Half of these clinics will be randomized into receiving the five-cog paradigm, which will be the cognitive screening test administered by community health workers before patients see their primary care physician. And the other half of the clinics will have usual care. So we're going to compare both these types of clinic that are assigned to both the arms and see our primary outcome is diagnosis of MCI and dementia. But we'll also look at some of the other care indicators like are physicians ordering the right tests for cognitive impairment? Are they doing referrals? Are they starting treatments for cognitive impairment? So we started the clinical trial about a year or so ago. We've completed enrollment in 2 out of the 22 sites. So we still have some ways to go, but we hope to complete the clinical trial by 2027. In addition to this, we are also have an implementation component of the clinical trial where we are examining implementation barriers at the level of the clinic, at the physician level, at the patient level, to get a better understanding of how can we improve care in primary care clinic. And the final piece that we are doing, which I think is important for studies like this, is we are partnering with a health economist, Dr. Dustin French at Northwestern University in Chicago, to look at cost effectiveness issues regarding five-cog. Can we afford to implement five-cog? The five-cog itself is designed, was designed as a pen and paper test. But it also can be upscaled to be included into digital apps or electronic systems, because we've made one major change in the 5COG, and that is that instead of requiring community health workers to measure gait speed, we've substituted that with a questionnaire that assesses gait. So the 5COG, or the 5COG 2.0, as we like calling the current version, includes 2 picture-based tests and a questionnaire. So it makes it even more easier to administer in primary care settings.
Well, Dr. Verghese, thank you so much for your time. And most of all, thanks to you and your team for this amazing work. And thanks to those who have listened to this episode of the podcast. We hope that you found it informative and enjoyable. Thanks again, Dr. Verghese.
Thank you so much for having me, Jen.
The Gerontological Society of America was founded in 1945 to cultivate excellence in interdisciplinary aging research and education to advance innovations in practice and policy. For more information about GSA, visit geron.org, geron.org.